for prevention. We have a fabulous panel today and delighted you could join us. I'm Laurie McDougall from the Partnership for Maternal, Newborn and Child Health in Geneva, and I'll be moderating today's session together with my colleague Mary Kinney of Saving Newborn Lives and Save the Children. We're really pleased to present this webinar as part of a series that the Partnership for Maternal, Newborn and Child Health is doing on evidence to accelerate action for women's, children's and adolescent health. And we're delighted to join you today with the support of the core group as well as APHA. We have 2 more webinars coming up in our series. Next month in January, we have one on adolescent health that I hope you'll tune in for. And then in February, there's one on quality of care for maternal and newborn health. So I'm sure the details for those webinars will be coming to you shortly. But for today, the subject is stillbirths, which we're really pleased to be able to present on. It's such a critical issue in public health. It doesn't get nearly the amount of attention it deserves. But there have been some positive momentum, and Mary will tell you a little bit more about some recent work that's been happening on stillbirths. So over to you, Mary.
Thank you, Laurie, and greetings, everyone. We thank you for joining today. I'm here to represent the Lancet Ending Preventable Stillbirth Series study and advisory group, as well as the Every Newborn Action Plan movement. Nearly a year ago, together we launched the Lancet Ending Preventable Stillbirth series, which was 5 academic papers and 4 comments, which had over 200 contributors from 43 countries and 100 organizations. This collective effort exposed the neglected issue of stillbirths. 2.6 million occur each year, and there has been little reduction in the past decade. Discusses policies, data, research and funding, revealing very uneven progress. Data for stillbirths has increased over the past few years, but there have been very few mentions of stillbirths in policy and funding. Stillbirth continues to be underfinanced despite the global health burden. So, assessed the impact of stillbirths on women, societies, and economies. We have solutions with feasible, practical, cost-effective interventions to end preventable stillbirths. The biggest challenges is stigma, and another big challenge is accountability and leadership, especially in countries. So this panel is here today to talk about the renewed call to action and what's been going on within the context of integrated healthcare. And we look forward to hearing from the speakers on how we're achieving these milestones and goals set out in the series.
Thanks, Mary. And what's really important to note, I think, is that it's fantastic this evidence is coming out, and we are making progress in terms of getting this issue up the global agenda. We had, for instance, the launch last year of the Global Strategy for Women's, Children's and Adolescent Health to support the implementation of the Sustainable Development Goals. And in the strategy, stillbirth is a core indicator, and that builds on the work in 2014 of the Every Newborn Action Plan endorsed by the World Health Assembly, where a goal was set of a reduction of stillbirths to 12 or fewer per 1,000 live births. So it's great to see some progress, but we need a whole bunch more, and we hope that today's discussion is a bit of a catalyst towards that, and that we give some state of play in terms of the evidence and some new ideas to think about, and more partnership building around the issue. So let me introduce you to our fabulous panel who's going to take us through this. We're very fortunate today to be joined by Dr. Hannah Blenko of the London School of Hygiene and Tropical Medicine. Hannah was a lead author on the Lancet Stillbirth series, and she'll give us the state of play on the evidence. She'll be followed after that by Dr. Martina Bai Lukong, who is the coordinator of the Government of Cameroon's National Multi-Sector Program to Combat Maternal, Newborn and Child Mortality. Her leadership has also been very well recognized at the global level. She was a mover and shaker on the Every Newborn Action Plan, so we're delighted to hear from her today. We also have Debbie Hain Vijayvergiya, who is an amazing parent advocate, who came by this in 2011 after the loss of her stillborn daughter, Autumn Joy. Her organization, ASAP, has been doing amazing work, and it's the power of parents that are really helping to move this agenda, and Debbie will tell us more about that. Betsy McCallum is with us. She's CEO of the White Ribbon Alliance. Betsy is also the chair of the Partnership for Maternal, Newborn and Child Health's NGO constituency, which now has, I think, 400 odd NGO members as part of that. Betsy will be talking to us today about how stillbirths are part of the quality of care agenda and a new global advocacy campaign coming up on quality, equity, and dignity. Finally, we'll hear from Kate Kerber, who's Senior Specialist with Saving Newborn Lives for Save the Children. Kate co-led the development of the WHO Mortality Audit Guide for stillbirths and neonatal deaths called Making Every Baby Count. She'll talk about how such tools can help users capture often overlooked data, especially for stillbirths. So thank you again to our panelists for joining and to our audience. So please, audience, we look forward to your questions. We'll take them at the end, and we hope that there are many. So I will hand over now to Hannah to take us through the state of the evidence on stillbirths in the world today. Hannah.
Thank you very much, Laurie, for the introduction, and thank you very much to everyone for joining us here today. I have a few slides I just want to walk through now, so just bear with me 2 seconds while I switch over to them. And I'm presenting today on behalf of a large group of authors from the Lancet Ending Preventable Stillbirth series and investigators as well. And we'll be thinking about stillbirths. Where are we now and where are we headed? Where are we now? Well, the Millennium Development Goals have been heralded as one of the great successes of human history, especially for the effect on women and children's health. In 2015, there were still almost 9 million deaths of women and children, and around 6 million of these were related to pregnancy and birth. Much to do for to end the unfinished agenda for the Millennium Development Goals and to ensure that no one's left behind as we enter the Sustainable Development Goal era. Center of the screen, and their mothers and families are in danger of being left behind. Progress in reducing these deaths is slower than that for older children or maternal mortality. And half of these deaths, they were not included in the Millennium Development Goals or routine tracking, and they have no target in Sustainable Development Goals either. Laurie's already touched on some progress we have seen over the last 5 years, with their inclusion in the Every Newborn Action Plan as a core indicator for the global strategy for women, children, and adolescent health. But large gaps remain, including funding for programs and research, specifically for stillbirth, gaps in work plan annual reports for global agencies working on maternal and child health for stillbirths. Into the data, but large gaps still remain. And no visible progress has been seen in response to previous calls to address stigma, taboos around stillbirth, or to improve care. 2.6 million stillbirths in 2015 is a story. These babies matter to their mothers, to their families who go through all pregnancy only to be left with empty arms. The cost to them is psychological, stigma, economic, physical. An estimated 4.2 million women are living with depression after suffering a stillbirth. These stillbirths also affect healthcare providers, affecting them personally and professionally, often experiencing guilt, anger, blame, anxiety, sadness, and fear of litigation or disciplinary action. These stillbirths also affect wider society, particularly in their economic impacts. 6 million stillbirths, and these refer only to third trimestral or late stillbirths. But these effects are also seen with earlier fetal deaths, earlier gestations. And if we count all fetal deaths after 22 weeks in these estimates, the toll would be even higher. Stillbirths, and 98% of these are in low and middle income countries. This map we're showing now shows stillbirth rates, with the darker shading showing the higher rates. Darkest green shading, up to 5% of all births end in stillbirth, babies that die before they have a chance to live. 75% of all stillbirths occur in sub-Saharan Africa or South Asia, with about 60% occurring in rural areas, often in conflict and emergency zones. These deaths are affecting families most underserved by healthcare systems, and we need to be rethinking strategies to reach these women and their babies to achieve the Sustainable Development Vision of leaving no one behind. 2.6 million stillbirths, and half of these occurred during labour. Here is shown the regional stillbirth rates, and the dark green part of the bars are those that occur during labour, intrapartum stillbirths. This has been described as a scandal. Most of these deaths are at or near term, would have been suspected to survive. We have interventions that work. We know that high coverage and quality of care during labour and birth is highly cost effective and reduces these deaths and gives a quadruple return, preventing stillbirths, reducing maternal neonatal deaths and improving maternal neonatal morbidity, and also improving child development. But yet more than 40 million women each year give birth at home without a skilled attendant or this care around the time of birth. And even for women delivering in facilities, the quality of care received is too often suboptimal, with large equity gaps at the poorest, most affected with the worst care. To understand how we can reach every woman everywhere with a skilled attendant in an enabling environment to prevent these deaths. 2.6 million stillbirths, and yet most are preventable. About the half that are due to childbirth complications during labour, and other big causes are maternal infections in pregnancy, such as syphilis and malaria, very preventable and treatable, maternal conditions such as hypertensive disorders and diabetes, other placental disorders leading to fetal growth restriction and placental failure from prolonged pregnancy, with less than 10% of all stillbirths due to congenital abnormalities. We have no official global estimates for the proportion due to each cause, because even in high-income countries, investigations are often inadequate and approaches to classification inconsistent, with more than 40 systems in use currently. Here, the World Health Organization launched the International Classification of Disease for Perinatal Mortality, ICD-PM, which seeks to go part of the way to address this. And we're going to hear more later on in this webinar about standardized perinatal audit, which could improve our understanding of cause of death. The series also highlighted the importance of overlapping risk factors, including maternal age, pregnancy spacing, maternal nutrition, smoke, and environmental toxins that also need to be addressed. So therefore, pregnancy to stillbirth needs to be an integrated approach along the continuum from reproductive health, with planning and preconception care, including family planning, nutrition, protection, education, empowerment of girls and women, and women's health. Pregnancy and high-quality antenatal care, high-quality childbirth care, and respectful and supportive care if a death does occur. 6 million stillbirths, most preventable. So where are we heading with stillbirths? Well, in 2015, the global stillbirth rate was estimated to be 18.4 per thousand. That's the green triangle in the center of this slide. As we've already heard, the Every Newborn Action Plan in 2014 set a target of the national stillbirth rate of 12 or less in every country by 2030. A gap in all countries so that no one is left behind. It's to a global stillbirth rate of about 9, which is shown as a star down here. Where will we be if we continue? Well, if progress continues as we are, we'll only be at that red triangle, way off the target. We're going to need ambitious change if we're going to meet this target, with at least 56 countries needing to double their rates of reduction. Can we do differently to bend the curve for stillbirths? Well, we've talked about the Every Newborn Action Plan, and these are 5 actions coming out of it. We need intentional we know we won't end preventing stillbirths without intentional joined-up action across many areas. This needs all of us. We need intentional leadership development, voice of women. We need increased implementation investment, particularly in human resources and healthcare systems, reaching those that are hardest to reach. We need improved indicators and metrics, improve the data to count every baby and her mother, and better understand timing, causes of stillbirth to track progress and enable action. And we need to be investing in research to understand the critical knowledge gaps. And this will go from discovery to implementation science. Many of these, I want to hear from you as we go through this webinar as well. But I think I'd say that we need integrated action, and we all have a part to play. So what will we do to ensure that stillbirths are not being left behind?
Thank you very much, Hannah. Mary, would you like to respond to Hannah?
Thank you so much, Hannah. The series says that most stillbirths are preventable. So where should countries be looking to get the most gains on their investment when trying to prevent stillbirths?
Thank you, Mary, and I think that's a very important question. Stillbirths are preventable, and we need to be doing action. And I think we've highlighted you need an integrated approach across the whole continuum. But of course, that involves lots of resources. And I think one place that we need to really be starting is the care around the time of birth. We've seen that half of stillbirths globally occur around the time of birth, whereas very few stillbirths in countries with strong health systems are around the time of birth. So we need high quality care to reach all women. That needs to start with the women who are already delivering in facilities. We need to be enabling our healthcare workers in environments that they can deliver high quality monitoring and care throughout pregnancy and particularly at time of delivery, to strengthen referral systems for emergency obstetric care should they require this, to see how we reach the disadvantaged women, the women that are left behind in every single country, particularly those affected by conflict and unstable environments. And I think in all settings, there's going to be different approaches to do this, but actually trained midwives are likely to form an important part of the solution for this in all settings. Knowledge gaps there as well. For example, how do we best deliver this high quality care in settings that are changing and vulnerable to conflict situations? And also how we better predict women who are at risk of having a stillbirth early to prevent these deaths from happening. And this is going to need funding and attention from the research community, from the global community. We're going to need this coupled with improved quality of care if we're going to end preventable stillbirths.
Hannah, thank you very much. Very clear messages with that. High quality care to reach all women. I think that's a theme that we're going to hear right through this, this webinar today. Thank you very much. And with that, I'd like to call on Dr. Martina Bai to present on behalf of the Government of Cameroon.
Hi, everyone. I hope you can hear me. I'm having some problem with connection here. It's my pleasure and honor to really be part of this panel to talk about stillbirths and let you know what's happening in Cameroon or what we intend to do. First of all, let me start by saying that up to about last year, our only source of information was demographic and health survey. And the last one that was carried out was in 2011, where we saw that the stillbirth rate was around 4.7 per every 1,000 live births. So if you can believe that those statistics, this is about 3,000 to 4,000 babies lost every year, you know, as stillbirths. So 2011, 4.7 per 100 live births, and in Cameroon we're having about 750 to 800,000 deliveries. So you can see the number of babies being lost, you know, in stillbirths. The risk factors, it's now that we are really going to look, we've decided to address stillbirths, but like in many of our African countries, this would be due to maternal conditions like malaria, which is endemic in Cameroon, syphilis, and obstetric complications. Yeah, syphilis because, and even malaria because we don't have, women don't attend care visits that they have to attend. So you can imagine that if it's not, this would be an issue. Now, what is being done or what do we intend to do about this? We want to, first of all, insist on having good data. We all know that, I mean, you can't have any good policy without good data. So that's why the very first thing we want to do is to build on, you know, make sure we have good information, good data source. So in addition to the DHS, which, as we know, comes on every 3 years, we are now going to, we actually started last year, 2015, where we, during the emergency obstetric and neonatal care survey that was carried out, stillbirth was really one of the issues that we looked at. A survey was carried out in more than 200 hospitals. Unfortunately, I don't yet have the report, but we included the issue of stillbirth as something to be sought out for. So when this is ready, we should know, out of the women delivering in hospitals, how many of these are presenting stillbirths. So the other thing is we want to, stillbirths have been included in our routine data collection forms. So this is being notified now regularly. It just started this year. So hopefully by the end of next year, we should have some data as to what's happening every day in the in the hospitals. We also started with maternal and perinatal death surveillance and response, and we have agreed that stillbirths should be audited, whenever it happens. In fact, a few days ago, I was talking with one of my collaborators, and she told me that in one of our hospitals around here in Yaoundé, during the maternal death audits, it was around a case of stillbirths. So that's already happening. And with that, we should hopefully have more information on which to build our action. So once the data and the information base is solid, we now, or alongside that, the other thing that we want to do is to really reinforce care during pregnancy and the perinatal period. Because as Hannah just said a while ago, that's the key thing to do around the perinatal period. Of course, we're going to do this through improved capacity building of healthcare providers and making sure that they have the right equipment around to monitor labor and delivery. We also, of course, are going to take this up as a case for advocacy to make sure that the policymakers, the families, everybody, is aware of the importance of this issue, and to know that something can be done about it. For example, the families, the mothers, if they know that by attending, the number of antenatal care, but now we know with the new guidelines that it has to be on like almost every month. If mothers know that they have to attend antenatal care frequently in order to avoid this, we think that would be something that would help solve this. We also have a technical working group for maternal and child health in the Ministry of Health, and newborn stillbirth is certainly going to be one of the issues to be looked at within this technical working group, without, of course, forgetting research and dissemination of information. We are lucky to have more and more medical students who come to look for topics that they could look at during for their dissertation. We think more and more will propose issues around stillbirth and newborn care generally for them to look at. So all of this is to enable us, as we have just we're finalizing the investment case within the Global Financing Facility, and stillbirths have been highlighted there as one of the things to watch out for. So we have given ourselves a target of reducing, moving from the 4.7 per thousand live births that I talked about to around 3 by 2020, which is the duration of our investment case. So we're hoping that with this, the advocacy, the data collection, and the healthcare reinforcement, we should be able to tackle the issue of start tackling the issue of stillbirths. Thank you.
Thank you very much, Martina. I think the leadership that Cameroon has shown in tackling stillbirths is an example, and the importance of sustained financing, the GFF case. This is very interesting in terms of the way forward for potentially some other countries as well. Mary?
Yeah, thank you, Martina. I think that this is a really prime example of intentional incorporation of stillbirths into maternal newborn child health mechanisms like the GFF. The Lancet series highlighted 3 criteria for intentional incorporation of stillbirths within an integrated agenda. One was including stillbirth as part of the burden of deaths, including specific interventions that will prevent stillbirths. And then the third was monitoring of stillbirths as an outcome. It spoke to all things and has been intentionally incorporating stillbirths. And so I guess the question would be, how has global advocacy around stillbirth influenced the national level action, and how could this be strengthened?
Thank you, Mary. As I just said a while ago, with the counting of these stillbirths and the auditing, during the maternal and the perinatal surveillance activity, we should be able to quantify how much of, what is the burden of this issue within our country. And then, of course, I talked a while ago about the necessity to really improve on perinatal care. I think that's what countries should do if they really want to improve on this. Because, for example, we realized that in the survey that was carried out, emergency obstetric and care that was done, hospitals where you had many cases of stillbirths were those hospitals where, there was very little use of the pathograph. Labor wasn't really as, monitored as it's supposed to be. I think, the talk, at the international level, at the global level on this issue has really influenced what we are doing. Because I remember we do see people now at meetings, every time they'll be like, oh, please, let's not forget stillbirths, because we have to monitor that, according to what is being said at the global level. So yes, the advocacy at the global level has, made people more and more aware of this, and has really helped, in having us keep that, keep a focus on that. Thank you.
Thanks very much, Martina. I think that's a very fitting introduction to Debbie's comments and the difference that sort of advocacy makes at the global level, but also nationally in terms of pushing things forward on legislation, on financing, on policy. Debbie, would you share your experience with us?
Thank you, Lori, and thank you, PMNCH, for the invite to speak today. As a stillbirth parent advocate, I, for one, am not taking this invite for granted. It shows me that the increasing awareness of global organizations and the parent voice must be raised, promoted, and integrated. Like you, I'm not formally trained in women and children's healthcare. Trust me, this isn't where I envisioned I would be at this stage in my life. But the moment I brought my lifeless baby girl into this world, my life took a tragic turn. The only way I can make sense of our tragedy was to give it a purpose and to do what I could to help others so that they didn't have to suffer a similar fate. I lived 34 years of ignorant bliss, never knowing what a stillbirth truly was or that I was at risk. I think that up until the time I experienced our stillbirth, I'd heard the word used maybe once or twice. But I soon learned that stillbirth isn't as uncommon as we are led to believe. Unbeknownst to many, stillbirth causes approximately 26,000 deaths every year in the United States. That's almost 2,000 babies a month dying, more than deaths resulting from SIDS and prematurity combined. Globally, we lose approximately 2.6 million babies. Unfortunately, even with numbers like these, stillbirth remains one of the most understudied and underfunded public health issues today. My main message today for this group is that ending preventable stillbirth in the US and around the world is possible, but requires a parent voice and leadership, and to date, insufficient. And the only way we will change that is to create a greater sense of urgency around the unmet needs in stillbirth that not only raises our social conscience and dialogue on the topic, but to also help generate increased funding for stillbirth research, education, and awareness. One common denominator across the board is parent advocates like me. But all too often we're left out of the conversation. And this means we are missing out on the greater opportunity to share our collective experiences to advance stillbirth prevention. And the situation for parent voice is even worse in countries with the highest number of stillbirths, according to the International Stillbirth Alliance. For those of you who don't know who ISA are, they are a consortium of researchers, practitioners, and parents focused on reducing stillbirth, the burden of stillbirth globally. I've learned from them that as for other countries with the highest number of stillbirths, there may be literally no parent organization at all, due in part to the abiding stigma, as well as low awareness, low political activism, opportunity, and poverty. Even here in the US, areas and population groups with higher poverty and thus higher stillbirth rates are also underrepresented among parent organizations. For instance, African Americans, recent immigrants, and non-English speaking groups in rural areas. At the end of the day, it's not acceptable and something has got to give. You may be wondering, how can parent advocacy make a difference? Well, parent advocacy is potentially critical in shaping the local, national, and global landscape of stillbirth. We can impact legislation, birthing center protocols, data collection, create awareness, and educate healthcare professionals and empower expectant moms. If this can be done on a local level, imagine the value of this network at a national or global level. For example, in 2013, I began working with New Jersey Senate Majority Leader Loretta Weinberg to get the state's first ever stillbirth legislation passed. On January 21st, 2014, Governor Chris Christie vetoed a record number of bills, but he passed the Autumn Joy Stillbirth Research and Dignity Act, which we named after our daughter. The bill requires state officials to develop policies and procedures to ensure that hospitals and healthcare providers are prepared to respond to stillbirth with sensitivity and to gather data that could be useful in researching their cause. I'm also proud to share that the Autumn Joy Act found its way into the Lancet's 2016 series on ending preventable stillbirths. Not once did I ever think I was someone who would pursue legislation or get it passed. In 2013, I became a founding member of the Action for Stillbirth Awareness and Prevention Coalition. We are a national coalition of individuals, groups, organizations, medical professionals, all dedicated to increasing stillbirth awareness. One major challenge for a majority of the parent-run stillbirth perinatal loss organizations here in the US is that they're underfunded and underrepresented. Many, though not quite all, require the founders to spend their own money to keep the organizations running, which often diverts focus and spreads efforts thin. These organizations need financial support to ensure organizations can be staffed appropriately, thus minimizing the dependence on volunteers who lack experience and may have competing priorities, which can often dilute the strength of our efforts and commitment. In conclusion, the first time people hear about stillbirth shouldn't be when it happens to them. We must break the silence and taboo around stillbirth. It's essential that we find ways to educate and empower expectant mom and families through childbearing years about the importance of prenatal care, risks and realities of stillbirth, and how to be an advocate for their unborn baby. We need to empower expectant moms to get to know their baby and their movements, so if there is a concern related to their baby, they can walk into their doctor's office with facts and not just feelings. And the only way we will ever be successful in improving stillbirth outcomes and ending preventable stillbirths is to unite parent voices, the organizations that we build, and find ways to collaborate with our government agencies and researchers. As a stillbirth parent, I sincerely hope that one day, very soon, we will find the leadership, ownership, commitment, and financing that we need to bring stillbirth out of the shadows so that it can be recognized as the tragic maternal health crisis that it is.
Debbie, thank you very much for sharing that story. Congratulations on the difference that the Autumn Joy Act has made. I mean, it's such a testament to what committed parents can do when they get together and act. And I'm always struck, you know, on these issues on women's and children's health, that when you compare us with, say, the HIV community and the way that people affected by HIV got together and stood up for their rights, it was a turning point in that movement. And I always feel that in this movement, especially when you have stillborn babies who can't speak for themselves, newborn babies, it is essential to get the voices of those most affected by the issues out front and center. Thank you for sharing that. Mary?
Yeah, thank you so much, Debbie. Your impressive and important work really demonstrates the power of effective parent voices. For the Lancet series, we had a number of effective parents as researchers and advocates as part of the series. And I know, having done a number of these with Lancet before, it made a huge difference having had effective parents as part of the writing group, as part of the research teams. And I think that that meaningful engagement of parents as part of our work is really critical. So I wanted to hear from you on how you see meaningful parent engagement on the global and national level, and then how to overcome those resource gaps that groups are facing to mobilize, because we know that within an organizational network analysis that was done for the series, that there was a number of parent groups that were also surveyed, but there's a disconnect between those groups and the number of the global organizations. So how can we improve that, and how can resources be mobilized? Thanks.
Of course. To me, having a meaningful engagement of stillbirth parents would involve having them spend time on the stillbirth scene, having a real verbal and physical presence there. But I can tell you that this can be very difficult and intimidating when global and national policy actions are not your background. Parent advocacy should involve a range of efforts, including public speaking, participating in meetings, attending congresses, working with other advocacy groups, speaking with KOLs or other media, as well as writing. Imagine trying to do all of this while having the priorities of a job that is not related to stillbirth advocacy at all, but it's just to bring in a family income, plus having family responsibilities, or even both. It's daunting. There are a number of conferences that I get invited to that I unfortunately cannot afford to attend, and I know that I'm not alone. So yes, the parent voice is needed and wanted, but it comes at a personal cost as well as financial costs. And as far as I know, there's no organization that mandates include financial support to enable parents to become more involved in stillbirth advocacy, or in my case, to continue their work. That's why I greatly appreciate being invited to today's webinar, because it's a step in the right direction. Not only because I, as a parent, was invited, but also because it was easy to participate in. I didn't have to buy a ticket or on a train or a plane to go anywhere, and I didn't have to coordinate childcare. As you can see, ultimately, including parents in stillbirth advocacy does add up to time, money, and education. The reality is that most grieving parents are largely unaware that there are things that they can do. And as for those that feel they need to get involved, which many parents do, they still don't know what it is that they can be doing, such as getting legislation passed, even doing their part to share their story. There's no guiding resource or playbook to accomplish these things, and no organization whose mandate is to fund the creation of such a playbook. And as far as the resource gaps, you know, I've pondered this question every day for the past 5 years. Funding is a primary concern, but there are some ways to improve those resource gaps. I think the first step is overcoming this. The main gap is to elevate stillbirth in our dialogue via a stillbirth awareness campaign. A strong national or global awareness campaign, we can start to elevate the sense of urgency so that stillbirth is recognized as the tragic maternal health crisis that it is. But ironically, a campaign costs money. I wish that wasn't the case, but it is. The fact is there isn't any awareness without money, and there isn't money without awareness. They simply cannot have one without the other. Experience, you know, I took it upon myself to secure a pro bono national stillbirth awareness campaign. Over the past 3 years, I've approached local and global ad agencies about this idea. And about a year ago, a global ad agency committed to taking this on, only to pull out 2 weeks later. Why, you may ask? Because it was too depressing of an issue. And this is exactly the risk that we take when we seek pro bono assistance. It is generously offered, but because there is no financial transaction or a legal agreement, you know, it's all too easy for these offers to be rescinded. And we're left right where we started, with no ad campaign and no organization whose mandate it is to fund such a thing. One possibility is that from the top-down perspective, federal agencies or larger organizations could perhaps create grant programs to help provide financial support for things like an awareness campaign, PSAs, legislation initiatives, etc. A grant program could also, for instance, help fund the creation of a list of resources that is presented to bereaved families at the hospital to educate them on how they can be involved if they want to be. Or it could fund the creation of a support of a volunteer network to help work to keep moving, or even the creation of a centralized online resource. At the end of the day, the fact is there's strength in numbers, and we must find a way to collaborate and work together and make a difference, parents, organizations, because every day that goes by without us making our best effort to improve stillbirths in the world means that there are more babies that will die and families that will continue to suffer.
Too true, Debbie. Thank you so much for that. And I'm just seeing a comment here from Leith Greenslade saying, Debbie Haynes should be on every RMNCH steering committee that we have, because the passion and the clear thinking is absolutely what we need. Thank you so much for that. Mary, to you.
Thanks, Lori. I actually think it's now over to Betsy McClellan to talk about the quality, equity, dignity, advocacy, which I'm hoping is going to also touch on some of the ways that parents can engage and the importance of the intentional incorporation of civil society and parent involvement in that effort. To you, Betsy.
Thanks, Mary. Thanks, Lori. And thanks, everyone. Yeah, Debbie's a hard act to follow, and thanks for sharing that, Debbie. It is really powerful. And what I'm going to share a little bit is what I see as a major opportunity in the coming year to really integrate attention for stillbirths. There's a growing focus on quality, equity, and dignity in the context of reproductive, maternal, newborn, and child health, which provides really an open door for engagement and elevation of the issue of stillbirths. A part of this is a framework and standards that the World Health Organization has developed, focused on improving quality of maternal and newborn care in health facilities. That effort is focused initially in 9 countries: Bangladesh, Cote d'Ivoire, Ethiopia, Ghana, India, Kenya, Malawi, Tanzania, and Uganda. And we'll work with these countries to develop and implement national plans for quality improvement under the leadership of their ministries of health, and with support from a wide range of network partners. And I think that piece is going to be really critical in terms of the inclusivity of those networks. And in addition to the focus on improving the clinical standards, a range of partners are beginning to develop an advocacy initiative, Quality, Equity, and Dignity for All, that very much will bring the voices of women and their families and the voices of health workers, as well as the organizations that work on their behalf, into the design and the implementation of quality of care. It will focus on human rights, so not only looking at this through the clinical lens, but very much elevating the goals of equity and promoting dignity and respect. As Hannah outlined at the outset, in the Stillbirths call to action, one key action was increased voice, empowering women to demand quality of care, supporting those affected by stillbirth to raise their voices for change, as Debbie has done, and reducing stigma, as several others have outlined. Voice and accountability are at the heart of the Quality, Equity, Dignity for All initiative, and we see this as a critical way to achieve the targets on maternal health, newborn health, and stillbirths as they've been set out in the global strategy. In terms of next steps, there's going to be a launch of the Quality, Equity, Dignity Network in Malawi in February. And the Quality, Dignity, Equity for All has been prioritized actually as the top priority in terms of the Partnership for Maternal, Newborn, and Child Health Advocacy plans. So there's great opportunity for many partners to get involved in the PMNCH advocacy community of practice to really engage to move this forward. So I'm hopeful that this is the opportunity to galvanize and gather support with voice and accountability really as the driver. Thanks.
Thanks, Betsy. I think the point on accountability and the importance of voice to accountability is central to everything we're talking about here today. Mary, over to you.
Betsy, you know, I really, White Ribbon Alliance and the leadership of the maternal community linked to the series has been really critical. 2 of the 3 milestones in the call to action were around respectful care and stigma. And one of the comments in the series was called Unspoken Grief, and it was assessing stories from and literature and academic literature from Africa around stigma and culture, beliefs and practices. And so I'm wondering how in these countries, these 9 countries, initially, and then maybe in other countries, the collective effort can work to address the social norms related to respectful maternity care and stigma around the loss of a baby. And it would be great to hear your thoughts on that. Thanks.
Yeah, thanks, Mary. I mean, I think it's such an important question. I definitely don't have all the answers. We're really at early days, and I think how we do that and is going to be very much with many partners, and it's going to look different in different settings. But yeah, as we've said, by putting voice and accountability at the heart of that, working to break the silence, I think is going to be a huge piece of this. And I think this opportunity, again, to integrate that rather than as a standalone is really important. Elevating women and families' experiences, which are often heartbreaking, into the discourse. One way, in terms of that storytelling approach and helping to break that silence, is perhaps in working with citizen journalists. And we've done this recently in Malawi, where midwives themselves, as citizen journalists, collecting and gathering stories from women and then elevating those into national media and into the policy discourse. And some of those stories, you know, are coming from women who have experienced stillbirths. One really heartbreaking story we heard from a woman who had to take her stillborn baby in a suitcase on the bus for hours back home after leaving the health facility because there was no plan or practice in place for how to deal with what had happened. No one asked her about it. No one had spoken to her about it until she had this opportunity to share with the Midwife Citizen journalist. So we hope many partners will join us in thinking about different ways we can unite, join forces, and help to break the silence on the issue. Thanks.
Thanks, Betsy. Those stories that you're reporting from this work, I mean, these are stories that just have to be shared widely. You know, the emotional impact of this issue is so profound, and the stigma is and the behaviors around that and the changes around that need to be addressed at multiple levels. So our last speaker today is Kate Kerber from Saving Newborn Lives, Save the Children. And Kate, would you please go ahead?
Thanks, Laurie, and thanks everyone for joining today. So as we've heard already, in most of the world, deaths aren't registered nor investigated by the health systems that could have prevented them. And this is particularly true for stillbirths. Knowing the true burden of deaths is important to creating awareness of the problem and allowing analysis of missed opportunities within healthcare systems and beyond. The major barrier to having comparable national level estimates of causes of stillbirth is not having had a single standard classification system, one that would be practical for use across settings with differing diagnostic capabilities. To better understand why these deaths occur and what can be done to prevent them, in line with calls from Every Newborn Action Plan, led to the development of 2 documents by WHO earlier this year, the WHO application of ICD-10 to deaths during the perinatal period, also called ICD-PM, and Making Every Baby Count, Audit and Review of Stillbirths and Neonatal Deaths. Making Every Baby Count audit guide provides methodology and tools to develop a system to investigate avoidable factors associated with perinatal deaths. Many countries have recently strengthened their maternal death surveillance and response platforms. As of 2015, 51 priority countries had a maternal death notification policy, compared to just 17 that had perinatal mortality audit and policy. These guidance documents will enable countries to build on existing platforms in order to improve care at the time of birth, linking to WHO's Quality of Care Initiative. Both ICD-PM and the audit guide keep the focus on the mother-baby dyad and help identify interventions that will potentially benefit both mothers and their babies. The tools include forms that can be adapted whether using a paper-based or electronic data system, monthly summary and trend calculators, support to classify avoidable factors, and ways to follow up on recommendations. In addition, there's a list of minimum information that must be collected on every birth and death in order to have basic data for decision-making. We know that identifying and recording deaths alone doesn't lead to change. In some settings, cases aren't selected appropriately for presentation at audit meetings. Data are interpreted poorly. It's hard to get staff to commit to meetings. Staff are afraid of being blamed or held legally liable. And recommendations are not clear or don't result in action. Health professionals trying to set up audit systems consistently said that they needed solutions to overcome these challenges. As well as providing data collection tools for local adaptation, the guide describes each step of the mortality review process in facilities and also proposes an approach to capture and review deaths that occur in communities. It provides information on establishing a legal and ethical environment that facilitates quality improvement processes without fear of blame or legal recourse. And finally, the guide suggests a way forward to scale up from individual facilities to district, regional, or national level, and how to create links to systems of surveillance, civil registration, and vital statistics. From frontline health workers to policymakers, we hope these tools can be used to increase the knowledge of the burden and causes of stillbirth, and also the preventative actions needed at each level to avert deaths in the future. This information has the power to make these deaths visible on national agendas and programmatic response, and in vital statistics systems. One exciting thing that we're working on now is an app for use on mobile phones, which is currently in development and will translate paper-based forms to a secure electronic platform. WHO and partners working in this sphere are providing technical guidance and support to implement these processes, working with professional associations and local academic institutions for sustainable implementation. One person can't do this alone, but we know that working together, we have the tools to make every baby count. Thank you.
Thanks very much, Kate. Your points about the power of data for change speak very much to Martina's story that she shared earlier. Mary.
Yeah, congratulations, Kate, to you and the team at WHO and all the partners around the release of the ICD-PM and the perinatal audit guide. I know that was many years in the making. And it's a major milestone in our community to see those guidance and the rollout and implementation. Here, though, an example of how this data and monitoring has been used for accountability in a country to change policy and even practice and resource allocation. That'd be really helpful, I think, to hear a specific country experience. Thanks.
Thanks for the question, Mary. And actually, the country you're in now, South Africa, has had a mortality audit system for maternal deaths, stillbirths, and early natal deaths, and in addition, child deaths occurring at public health facilities. And that's been central to tracking and measuring progress in the country. It also serves as an important data source to triangulate routine HMIS and vital statistics data. And at one time, those systems were completely based on opt-in at facilities, but now the process is mandated nationally and overseen by committees at the highest level, reporting to the Minister of Health. And the country's MNCH targets and priorities are based on these recommendations. So that's really exciting. But I spent last week in Zimbabwe and saw some great examples of how local mortality audit data are being used to affect change right at the point of care. And in one district, there was a really high intrapartum stillbirth rate amongst unbooked women. And this was identified actually by midwives upon reviewing the trend data at audit meetings. And they involved management in the recommendation that all women referred into the facility should be seen by a doctor as soon as the woman is admitted. And the midwives need to review and continue to use the original partograph that the woman came with. And this resulted in a time from admission to delivery, and an immediate and sustained decrease in those intrapartum stillbirths, which was really exciting to see over a short course of time. So the solutions don't have to be high tech or complex, and they can't overcome every barrier, especially beyond the point of care level. But when these changes come from within, they can be really powerful.
Thanks so much, Kate, and thanks to all of our panelists for their interventions. So we have 10 minutes left in our discussion today, and a few questions that have come in from our viewers. And if anybody is thinking about a question that you haven't yet sent, please go ahead and do it now. Otherwise, I'd like to start with the question that we have received from Mika Kiplagat from Christian Aid in Kenya. And the question is, what additional resource and capacity needs to audit stillbirths are required? And I'm looking at that, I'm looking at Martina to answer that question in her context in Cameroon about additional, and you've spoken to this in your introductory comments, but your thoughts on what tools, resources, training is really necessary to do effective auditing of stillbirths. Martina?
Could you come again? I didn't get you.
Yes. The question that's come is, looking at your experience in Cameroon, what additional resource and capacity needs are there to effectively audit stillbirths? So tools, money, resources, policies, people.
I think the WHO has brought out this guide on maternal perinatal death surveillance and response. That's where we got everything. I mean, the tools are there, and we use that to train our staff. And now they have started, and of course, it also takes follow up. Don't allow the people on their own. You make sure you go and at least see how the they're carrying out 1, 2, or 3 of those, then you're sure that they can, you know, they're doing it the way it has to be done. So yeah, we have the WHO guidelines, which are quite comprehensive, which we have used. That's what we're using to train our staff, and then we make sure we follow them up. Thank you.
Thank you. The next question has come from Leith Greenslade, and her question is, how do you get major media outlets across Africa, across Asia, to do what the New York Times did with its powerful Stillbirth Your Stories piece in June of last year? So I don't know if any of our panelists are familiar with what the New York Times did. Betsy, I'm wondering, or Debbie, you know, sitting in the US, if you're familiar with that, but I suppose from its title you can imagine what it was and what it might have accomplished for a readership that might not have known that much about stillbirths to begin with. So essentially the role of media and what can it do on this issue at the global level, but also taken from a country perspective. So Betsy, if you want to go first.
Yeah, thanks. No, and I am familiar. It was incredibly powerful indeed. I mean, I think in general, you know, on these topics and working with the media is about involving them as partners from the outset. I think often, you know, we go to the media as a target somewhere down the line, and you know what we have found is that engagement from the beginning. And not just with journalists, but with media houses themselves. And in a number of African countries, that's been a really powerful way of getting the media houses engaged and understanding the issues. And then we have found this kind of intersection between helping to pair sort of the traditional journalists with citizen voice, with health workers' voice, and forming some partnerships around that. The Malawi example I was giving, where these midwives have been trained as citizen journalists. Several different media outlets have been committed to publishing at least, you know, I think it's 5, you know, over the course of 6 months or something, you know, getting a bit of a regularized kind of schedule around that. It's kind of feeding them and providing stories to them. So I think it's about that intentional effort and relationship building and, you know, kind of connection from the outset, because they're incredibly compelling stories, but we also do know the solutions. And I think that's the other piece that media are looking for is, do we know what needs to be done? Do we have the answers? And we do in this case. Thanks.
Debbie, your thoughts on this?
I mean, I think that Betsy said it all. My experience has been, it hasn't been as positive. I mean, I've been fortunate to get a few articles published here and there, but I have been pounding the pavement for the past 5 years, trying to get my story told and trying to gain exposure for stillbirth. And it honestly, most people don't really want to talk about it. It comes back to the ad agency. And so I think that, you know, my personal take on it is that once more people start talking about it, maybe in public figures, I feel like maybe our media will be more willing. I agree with Betsy that you need to go to them as partners, but I have a very different experience here. People don't seem to be as willing. So maybe if more people are talking about it, I'm more interested, but until then, I've been told no so many times, I've lost track.
That question of champions is an interesting one, you know, and breaking the stigma, you know, through entertainment, celebrities, political figures, people who can really sort of reach through. And it reminds me of some work I did years ago. I used to work for the BBC Media Action on leprosy in India. And stigma was obviously very central to the issue that we took up then. And it was entirely through two things, through the use of very well recognized entertainment figures that can carry a message, but also very savvy advice, actually from a famous ad man in Bombay named Alec Padumsey, who said, to get to the head, go through the heart. You know, so having an emotional approach to these stories, such as perhaps what the New York Times did, helps to kind of break through a little bit of that. But yes, I mean, in general, the point is extremely well taken. You know, media is absolutely critical to moving the needle on this issue. So we're just coming to the end of the time that we have, and I want to give an opportunity to turn over to Mary for any concluding thoughts. You know, Mary, as you said earlier, you know, as editor, when you set out doing the Lancet series, you know, in 2013, 14, published last year, it was a long haul. But it was an incredibly impactful series, and lots of lessons learned, and a lot of great intentions about how to really ramp up this campaign, this global campaign. So here we are, you know, end of 2016, beginning of 2017. There's a 1-year anniversary for the series coming up, and we understand the Lancet wants to make some noise about that 1-year anniversary. What are your thoughts?
Yeah, thanks, Lori. I mean, it has been a very much of a collective effort, and we do want to see what's going to happen a year from the release of the series, what's been going on for Stillbirth. And this webinar has been a great opportunity to hear some of the progress that has been gained. And I think we have to build from success to success as we're moving forward. We know, and we knew when we set out to do this series, that the burden was great and was not visible in women's, children's, and adolescent health. We know that preventing stillbirths will also prevent maternal and newborn and child deaths, as well as reduce morbidities and disability. And addressing bereaved care is also going to improve respectful care and reduce stigma. We know these things, but it's so important. And I think this panel has highlighted the importance of involving parents and elevating the voice of women and families that have been affected to really go to the heart of the matter. And so with that, I really think we need to carry this on and see how we can elevate that story, and particularly in these countries where the burden is greatest and the stigma is greatest.
Yeah, exactly. So thank you again to all of our panelists for today, for the discussion we've had, to everybody for joining. It's such a passionate issue with so much to be done. And I wanted to throw out an invitation to anybody who's listening, who's interested in doing a bit more, about joining in and doing a bit more. We do have a working group that is doing campaign strategy for continuing on the effort that was launched last year with the Stillbirth series. Our next meeting will be next Thursday, the 15th of December at 11 o'clock Eastern Standard Time. After this call, the Partnership for Maternal, Newborn and Child Health will send out to all of you registered for this call the dial-in details and some background about these meetings if you would be interested in joining together, because partnership is really what this is all about, and we need everybody's voice, no matter whether you come from civil society, the private sector, government, healthcare professional background, youth groups. We need you all on this issue, and we need to become bigger and stronger. So thank you very much for that and for joining us today.
Yeah, we thank our viewers for joining, and on behalf of PMNCH, APH, and Core Group, we wish you a good afternoon, a good evening, good morning. Bye.
Bye.